I'm afraid I can't stay much longer than this presentation, unfortunately, but my colleagues Helen and Amanda, who are now recovering from their green state, are outside at the stand if you want to talk to them further. I should hasten to add they're not nurses, and something like this is quite extraordinary to them to see the reality of what we're dealing with day in, day out. My opening slide does make reference to making every contact count, and Paul has illustrated that beautifully, because we so often do the things that are in front of us, and we need to think much more about the prevention, what we do as a consequence of what we're seeing at any one time. And that was really illustrated very well for me when I went to visit the Mottingham Leg Club, where people were really interested in the whole person rather than just the leg ulcer. And it was a really dramatic illustration of making every contact count. All this has the context of the Francis inquiries. Compassion in Practice as the national strategy wasn't a response to Francis. It's slightly ahead of that, but nevertheless we had a real insight into what Francis was likely to say. And his intention, despite his 290 impossible to remember recommendations, is that he wanted to bring about a cultural change. And a lot of that is being achieved, but I think it will only be achieved in a whole-scale way if we recognise this is not just about hospitals. We've got to do it for the whole system. That's health and social care right across wherever people are cared for, including in their own homes. Compassionate caring we've heard a lot about, and that is of course really important. But there are times when I have to have discussions at the Department of Health about compassion not just being enough, because there are times when people can be lovely but lethal. And having knowledge, competence, skills and everything that goes behind that is really important. Compassion in itself is not enough. A couple of the things that the politicians have latched onto about what Sir Robert talked about was being honest about failure and improving accountability. Now, accountability for us on the Nursing Midwifery Register is a given, but it doesn't play out necessarily if you're a general manager, because you've got nothing to be struck off from, but you should be held accountable for the services that you manage and design and fund. So that accountability piece, I think, is going to be really important in the future, and we'll see developments about being a fit and right person to actually be a director of an NHS organisation. But a lot of this comes down to the fact that we need really strong leadership in all sorts of services, and that's not easy to come by. And that's leadership at all levels. That means everyone in this room. It doesn't mean this is positional power because you're an executive nurse or you've got a swanky job title. This means everyone exhibiting their leadership skills, because actually you know what is the right thing to do, and it's sometimes very hard to get that message across to colleagues, and that does take a fair amount of courage. Now, compassion in practice was chunked up into 6 action areas, and you'll see on the circle there that the 6 C's are quite prominent, and love them or hate them. And a lot of people didn't like them in the beginning and thought they were rather simplistic and patronising, have come to have a great deal of currency. And it struck me when I was talking to some midwives once, where there were some members of the Maternity Liaison Services Committee in the audience who are lay people. They're women who use the maternity services. And the resonance of the 6 C's with them was what struck me. The professionals didn't like it, but the public and patients think that they are what should happen routinely. And one of the leaflets on the stand outside that Amanda and Helen can let you have is based on that sort of experience. This is someone who is blogging about 6 C's in reality through their access to services, having first thought that they were really a piece of nonsense. But nevertheless, they are important for us professionally to engage with, because patients and the public do like them and recognise that they're important for us to do. Now, a lot of work has been done on these 6 action areas. I'm responsible for Action Area 1, which is helping people to stay independent, maximising well-being and improving health, which is an absolute nightmare. It is huge. It straddles the whole health and care system. And if you think about the care system, it's bad enough talking about the NHS, but in the care system, where there are nursing homes, independent providers, there are 22,000 employers. Absolutely impossible to reach out to all the nurses who are working in very difficult and isolated circumstances in those settings and to make a big difference. But nevertheless, the challenge is there. And I will touch on some of the other action areas as we've been making progress, and you will see some of the things that we've achieved as a consequence. Metrics has been really important, and I've even had a discussion this morning about how important metrics are. And it's not just number crunching for the sake of it. It came across, in Paul's presentation that we need the evidence, we need audit, we need to understand what outcomes are, not all the inputs necessarily that we put into running a service, how important they might be. But what difference are we really making? And this publication from King's College London was really important in helping us understand what the metrics should be around both services but also staffing, which has been a really important consideration in all this discussion. And the middle document there was from the National Quality Board, which is about staffing and getting the right people in the right place to do the right thing at the right time. Not as easy to do as it is to say. And that has been subsequently supplemented by NICE guidance, which is really important and helpful. But again, it's focused very much on hospitals, and we need to do much more work in understanding what the district nursing caseload is, for example, what the health visiting caseload is, what general practice nurses have to offer to primary care. Because we have that situation beautifully hidden at the moment, whereas there has been a big spotlight on hospitals. And then compassion in practice is just over a year old. We've just come up to the end of the second year, so we've had a 1 year on document to sort of take stock of what we've achieved and what we need to do more of. And as we go into the third year, of course, we're still focusing on those 6 areas of action, because there's still a lot to do about staff experience, about leadership, and about all the preventative things that we need to do rather than the curative. And there's still a lot of work to achieve, but we've got to now think about the year beyond compassion in practice. And for people like me, of course, at the Department of Health, we've got to think about the situation beyond next May, when we have an election. And a lot of this, of course, will be future-proofed, because no politician is going to argue against quality, high-quality care. But it's how we achieve it, given the pressures that we know we're under at the moment. One of the things that we've done as part of this at the department and in conjunction with Public Health England is to develop a framework for personalised care and population health for nurses, midwives, health visitors and allied health professionals. And this is the brainchild of my boss, Viv Bennett, who is both Director of Nursing at the department and Director of Nursing at Public Health England. And this is a screen grab from the Department of Health and the Public Health England website, where you can actually start to look at this tool. And it's intended to be helpful to all sorts of practitioners, because there are things that are important to all of us. But of course there are super specialists in public health who really do need to understand what population health is about, whereas we might more commonly be dealing with individuals or communities, but not necessarily huge numbers. So really important development. To make some sense of it, we've used some evidence which on the left-hand side, the right-hand side, there of the screen, you see that circle that's known as the Minnesota Wheel. And that's some American evidence about how this plays out in reality, how we look at practice, how do we make every contact count, how do we make a public health personalised preventative intervention when actually you're doing something else like dressing a leg ulcer. So although this is very busy, it is just intended as a snapshot to connect at the pyramid, everyone's business at the bottom, the super specialists at the top. The circle at the right illustrates the fact that this is about the whole life course. This isn't just about a particular snapshot, it's about the whole system, it's about health and social care. And that we're not deviating from the outcomes that are in the NHS health NHS outcomes framework at the moment and the public health outcomes framework, but there's also an adult social care outcomes framework, which we need to make greater scrutiny of, I think, in nursing, because it's one of my favourite statistics at the moment that was actually quite shocking when I heard Jackie Smith, who's the Chief Executive and Registrar at the NMC, say that only 40% of nurses on the UK register work in the NHS. So 60% we've got to reach in some other way. So, you know, there's a huge amount of nursing that goes on in social care, in the independent sector, education, research, forces, and way beyond. And reaching that 60% is really difficult but hugely important. So, although I might be preaching to the converted, it's really important that we carry that message way beyond these four walls and beyond the NHS. To make sense of this framework, we're actually making sure that we can put some live examples in it, and this one that we've done so far is about tuberculosis, and my colleague Jean Christensen is working on a range of others, so that it's not just a theoretic framework with evidence behind it, it's actually got some practical illustrations as you go through the website to look at various conditions, and we will develop that over time. So tuberculosis is live at the moment and others will be coming. There's more detail there which actually gives you hyperlinks into where you can get into the deeper evidence should you wish to look at the NICE guidance, should you wish to look at other things that are associated with it. And I think this is a really important document and a really important initiative, and the Minister touched on it in his speech about transforming primary care. And you'll be aware of these sorts of statistics that actually there are people of greater age in society, they are living longer with more long-term conditions and probably more than one long-term condition. And they are the people on your caseload who you will be seeing repeatedly. And of course, we need to recognise that services need to change, be redesigned as a consequence of that. We can't keep doing what we've always done because the demographics of who we're seeing are changing quite significantly. And this initiative will help. And it's starting this month with this so-called proactive care programme, which is about personalising how this care is given through an accountable GP, but also through a range of healthcare professionals. And I think this is a stimulus for quite a significant change. Very early yet, but it will give us a sense of what is needing to be different. And the commitment in that is to have 10,000 healthcare workers trained to give personalised proactive care by 2020. That's quite a significant ambition. What you don't see on that in that phrase is that they're new. And how that is actually achieved is going to be a challenge both for the service, for Health Education England and beyond. But I think it's a greater impetus for multi-professional education, it's a greater impetus for multi-professional team working. But actually it puts people like my mum at the centre of this, you know, those people who are really important to us all. But it comes down to, if it's really personalised care, what do those individuals need? And we wrap the services round them, rather than saying, oh, Mrs. Foster, you can access this because that's what we as professionals have decided to deliver. So really challenging stuff. The beauty of this, of course, is it comes with a great deal of money with it, which will help actually change some of this. And I said I'd touch on some of the Health Education England challenges, because I think they're really important. And they come out of compassion in practice, and some of the consequences of compassion in practice are now being realised through what Health Education England is doing. The first initiative is that there's something called the Shape of Caring, which is a review of nurse and healthcare assistant and care assistant education across the system. This is the shape of caring. It's not the shape of nursing in the NHS. Big difference. This is shape of caring looking 15, 20 years ahead. And this is a collaboration between Health Education England and the Nursing and Midwifery Council, and it's chaired by Lord Willis, who you may remember did a review for the Royal College of Nursing into nurse education a couple of years ago. Well, he's building on that work and making sure that some of this is being future-proofed, and this is really helpful for us when it comes to publishing the report in February, because it'll be ready for the next election. It'll mean that we've got some evidence about where we need to go with nursing, despite what, I probably shouldn't say this, but I will, but despite what politicians might decide next May. The Cavendish Review Care Certificate, Camilla Cavendish looked at the training of health and social care assistants and found it wanting. There's no doubt about the fact that some people are trained extremely well, but there is also a sense that some people are taken off a 41 bus, given a uniform and told to go into a caring role with very little training. A lot of people are accessing national vocational qualifications for this. A lot of people were putting on their own training programs. There was no consistency, no standardisation, and it was felt sensible that there should be a care certificate that is relevant to health and social care, so that people who are accessing this and actually get the certificate have transferable skills between health and social care. They will help integrate, they will understand both settings in a way that others don't, and fit themselves for the future and how they might progress on to nursing, physiotherapy or whatever they wish to. But also, and I think this is crucially important, also the care certificate makes that a meaningful and important role. Caring of itself is absolutely crucial, and it's a really valuable and rewarding job, and you don't necessarily need to do anything else and be on a great career trajectory, but it's a platform should you wish to. Apprenticeships are being promoted by this government as a really good thing as well, and there's some work going on about what a nursing apprenticeship might look like. Apprenticeships are not new by any stretch, but apprenticeships don't yet connect with what undergraduate nursing might be. So how do you access undergraduate nursing if you are an apprentice and want to go in that direction? So we've got to straddle that gap and make sure that in this initiative that people who want to access nursing as a career have a wide entry gate. They have access that appeals to many, many people. And if they have the right values, behaviours and attainments through the apprenticeship, can get into nursing or any of the other clinical professions should they wish. The care experience pilots you've probably heard of that Sir Robert recommended in his inquiry report, that people should have at least 3 months caring experience before they became student nurses. That got embellished slightly to become a year of caring. And Health Education England have piloted that very successfully, but it's taken quite a lot of infrastructure and systems and processes around this scheme, and not to say money, to go into it to make sure it works properly. And I think we will head for a situation where if people don't have caring experience before they want to be student nurses, they might have to get it somehow. Most universities exercise that anyway. It is not a bad idea, but how it is achieved, how it's funded, what it really looks like, and that there's actual benefit to this is really important. Recruiting for values I've sort of touched on anyway, because we don't recruit nurses for their academic ability. That's absolutely nonsensical. You've got to recruit people who have the right values and behaviours as well as the academic attainment to be decision-making nurses. And that's where the beauty of the 6 C's plays in, that each of those values and behaviours becomes a basis for recruitment. And if you can't demonstrate those, then all the academic ability in the world is not going to make you a good nurse. And the Nursing and Midwifery Council I will just touch on as well, because there's important stuff going on there which you are probably aware of. But it's worth re-emphasising that we are heading for a revised code. I've had an email this morning saying that there's another draft for me to look at. And some of the concerns about the consultation so far that you may well have contributed to are that it is too long and it is repetitive, and it only works if you're in clinical practice. And clinical practice is really important, of course it is, but there are lots of nurses who need to be registered who don't have clinical practice. Many of those are in public health jobs. They don't really have patients to lay hands on, but are highly influential. Many are researching, many are teaching, There are even policy geeks like me that need to stay on the register. And that's really important, that it works for the whole of the nursing community. That's a real challenge. The revalidation piece, of course, as well was stimulated by France, is about how nurses continue to be fit to practice and how that judgment is made. It's not just a matter of filling in a form annually and paying a fee, that it's actually based on some evidence about your practice. And that's coming to fruition and is suggesting that it will be based a lot on appraisal because it should be something that's happening anyway, and also that there's confirmation about your practice from another registrant. Now, how that works in reality, we're still thrashing that out. But this too has been a matter of consultation. So I think that every time the Nursing Midwifery Council come out with consultations, it's really important to contribute to them because your voices matter, they do count. And as I often say to people that don't like doing these things, well, shove something in, anything is better than nothing. And if you don't feel that you're being asked the right questions, well, don't answer the questions, give your opinion anyway, because it's really important that the whole nursing voice is heard. And there may not be very many midwives in the room, but there is also a review of statutory supervision of midwives. So if your midwife colleagues have not heard that, then the King's Fund are undertaking a review for the NMC, which is being published in December. And that's a really big deal about statutory supervision for midwives. How is that going to look in the future? How does that dovetail with revalidation? So really important stuff for you to contribute to. And for all the policy stodge that I may have touched on, for all the things that are on the go, if it makes absolutely no sense to you, make it personal. What would that really mean for me? Would that really mean for my practice? What does that really mean for my mum? And it's really important to consider how you do develop that in your own world, in your own thinking. This picture is from a visit I made to a Shore Start Centre, and this very entertaining child. I really wasn't about to pull a revolver on him, but he was quite a character. And that reminds me that some of the work that we're doing in the very near future is around children and young people. And to watch out for, on the 17th of November, we're having a week of action about children and young people's services. So if there's anything you want to contribute to that, please let me or my colleagues Helen and Amanda know, so that we can weave it into that. Even if you've just got a good practice story, you want to blog, want to give us some insight into what best practice should be and your experiences, then please let us know, because it's really important that we make this as real as we can. So there you are, a whole range of things that are really helping us to form the future. The future is really quite exciting and dynamic, but also there are lots of concerns and challenges. And as the Minister said this morning, it's really important to recognise the value of nursing, not just to patients but to the broader society, and how we make this play out for the future of ourselves and those we care for. Thank you very much.